when you look at trauma patients, trauma leads to hemorrhage, and hemorrhage then subsequently can lead to shock, which may or may not be reversible with appropriate resuscitation, but we know that hemorrhage and shock can also lead to coagulopathy. All these things can ultimately lead to the death of a patient, which is what we're trying to prevent. So the concept of damage control surgery was really developed some 30 years ago. And since then, what we've decided is we want to stay out of trouble rather than get out of trouble. And so surgical control of hemorrhage is important. Resuscitation is important in the correction of coagulation, hypothermia, and acidosis. And in that process of resuscitation, really ultimately our goal is to improve tissue perfusion and reverse the shock. And ultimately, so that we can get to definitive surgery to live to fight another day. And so when you think about this concept, before damage control operation, we would go from the ER to the OR. And you keep operating until you fix whatever problem that is. Well, that's a problem because then the patient ultimately develops metabolic derangements that you cannot overcome. And as we know it, and I'm going to remind you over and over again about the lethal triad of trauma, which is the acidosis, the coagulopathy, and the hypothermia, which we all deal with in the OR. So that's a concept that we no longer use because in damage control, what we want to do is we want to take a break. We're going to let the patient take a break. So we're going to go from the ER to the OR, get control, go to the ICU, reverse the shock, go back to the OR, and then ultimately to the ICU in that process to break up the entire resuscitation process so that you can correct the metabolic derangements before you go back for definitive surgery. The concept really is sort of like that ACGME nap break. You got to take a break before you can go back to work. That's what the patient's doing. So the traditional way of resuscitation is serial escalation of products, right? You start with, ATLS teaches us, start with 2 liters of fluid. If that's not enough and the patient's still hypotensive, we go with blood. And once you've infused a certain number of blood, and usually this is when, you know, a couple of hours into it, somebody's looking up from the OR table saying, hey, we don't have any clots. Anesthesia's sending coags. We're waiting for the coags to cook. We're waiting for FFP to thaw. That process is delayed. And it's kind of like starting a race a minute behind everyone has started. Running, you're not going to win that race. So that serial escalation is no longer considered the standard, and we're changing the way we think about it's the paradigm shift, really. We want to prevent coagulopathy rather than catch up to dilutional coagulopathy. So what we want is serial parallel resuscitation of blood, red cells, and its components. Because really, when you think about it, the patient isn't bleeding out just red cells when they're massively bleeding. They're bleeding whole blood, and whole blood is composed of the different types of components that you can transfuse. So what is the average blood volume? When you calculate it out, it's really about 4.5 to 5 liters in an average adult, or if you have a child, then that calculation is weight-based, and it's about 70, 80 mLs per kilo in a child. And the composition of whole blood is really 45% red cells, plasma, and then very little of that is composed of platelets and leukocyte. And what is the definition of massive transfusion? For most of us, it's greater than 10 units of red cells in the first 24-hour period. And so you would think that in the last 50 or 60 years of trauma surgery, we've recognized that patients bleed to death, and that's an acute problem. We would have some kind of protocol for transfusion, and yet we don't. Maloney in 2006 was really the first to address the fact that we don't have a protocol. If you look worldwide, some 2 million people die from bleeding-related trauma injuries per year. That's a significant number, and no one around the world at that time had a standard protocol for transfusion of the bleeding patient, who we know will get coagulopathic and die from the bleeding. So what they did was they said that we need to start and have a ratio of component transfusions so that it would be easy for everyone to resuscitate the bleeding patient. And what you start with is a ratio. When they looked all around the world and they kind of looked at what whole blood is, they wanted to do 1-to-1-to-1 ratios of red cell, FFP, and platelet transfusion while checking your coagulation factors and giving cryoprecipitate when indicated, because that has the highest concentration of fibrinogen. And in plasma, you get about half of the amount of fibrinogen that is in cryoprecipitate. So when the fibrinogen level gets so low that you can't keep up with the needs, then cryo needs to be given. And once the bleeding stops, then you can go back to the restrictive transfusion triggers that we all know and use in the ICU, but in the acute setting, the restrictive transfusion triggers really have no role as the patient is still actively exsanguinating. So first comes the recommendation for a protocol, and usually what happens and what follows is retrospective studies from different institutions looking at what the result of having that protocol is. And most of the trauma data, as you all know, initially comes from the military data. They're the ones with the largest population of bleeding people that they treat. And so really, the Sentinel paper that was put out in recent years on massive transfusion is by Borgman et al. And what they looked at was a group of trauma patients, soldiers to be specific, in Iraq over a 2-year period who received different ratios of blood and its component in transfusion, and they looked at the mortality of these patients and how well everybody did. So there were 3 different types of ratios, because at that time they're doing a retrospective review, so some of these patients did not get the 1-to-1-to-1 transfusion, and so they had the low ratio, which was the old form of transfusion where you started giving red cells and you didn't give plasma, you didn't give platelets until the patient was coagulopathic or had some other indication for it. And then there was the medium group and the high group of the ratios of plasma to red cells transfused. And what they found was that in that group of patients, their study population, it's a little bit different than civilian trauma because most of their patients were had penetrating trauma. So in what most of us think of penetrating trauma is there's one thing or 2 things that you know is injured, there's something definitive that can be fixed. And their average ISS, which is an injury severity score, was relatively low at 18. But what they did find was that, I'm sorry, let me go back to that. What they found was that the lowest group of mortality was in that group of patients who had the high plasma to red cell transfusion ratio, meaning if you gave them what they bled out, which is plasma and red cell in equal concentrations, their mortality rate was significantly lower than the other groups of patients who received sort of parallel transfusion or not enough plasma. And when you kind of look at and separate out why people died in the different groups, what they found was that basically hemorrhage was the initial problem in the first 2 groups of patients who were receiving the low ratios of transfusion. That the majority of these people died within, if you'll look at the time of death, I'm sorry, this slide is a little small, but the time of death is about 2 hours because they all kind of bled to death. Whereas the high group of transfusion patients, their death took about 38 hours. So in the first 24 hours, they didn't die. If you gave them enough blood and blood products, they weren't bleeding to death. They ultimately were dying from other causes. And you don't get to the other causes if you already bled to death. So when you think about transfusion and the risks of transfusion and some of the factors that you talk about in the ICU, such as ARDS, sepsis, increasing the risk of infection, those are problems of the living patient. And if you can't get the patient to the point of living, you don't need to worry about those problems. So this paper basically told us that there were fewer early deaths from hemorrhage, which we all know is an initial problem in the first 24-hour period that most patients die from bleeding. And so really, this is the extension of that damage control philosophy. You don't want to get into trouble. You kind of want to stay out of it. And you know that they're going to get dilutional coagulopathy. That dilutional coagulopathy is a problem of the bleeding patient, not a problem of resuscitation, and not really a result of resuscitation. But it was started as a result of the bleeding patient. So how does that really kind of translate into civilian work? Because civilian trauma is significantly different than military trauma in the sense that most of our patients suffer blunt injuries rather than penetrating injuries. And the ratio is really kind of reversed. Most centers look at about a 70% blunt trauma ratio to about 30% penetrating. And most of our patients are older. In the previous study, the military population, their average age was in the mid-20s. Our patient population is around the mid-40s. That's the average age of the trauma patient that we deal with. And we have slightly more female patients. So from that military work came quite a few civilian studies, which are all retrospective in nature. There are no large prospective randomized trials on whether or not massive transfusion protocols save lives. And that has been a problem and sort of the reason why everybody is kind of criticizing some of the positive results of the massive transfusion protocol, because you kind of have a survivor bias in most of these studies, because you kind of have to live through the ability to get transfused before you can actually be part of that data set. So out of Stanford comes this study shortly after the 2007 study from theater, which basically what they looked at was they initiated a protocol, and retrospectively for 2 years they evaluated how their protocol affected their patient population. And they compared those patients who received the massive transfusion protocol, that's the post, to the patients who did not undergo protocol transfusion, but rather sort of that serial escalation of care. And what they found was like pretty similar to our patient group here in San Antonio. Their average age, the amount of blunt trauma they sustained, they were able to pretty closely match the groups. And as you can see, their injury severity scores are relatively high in the 30s range. And so that's their patient demographics. They had a pretty good match group of patients, but small sample size. Notice that each group only had about 30 to 40 patients. What they found was that ultimately they had no difference in the amount of products given before and after massive transfusion protocol in their patient group, meaning before that they still did, whether or not the ratios were given in parallel or not, you can't tell in their retrospective study because they just didn't look at the timing of the transfusion. But what they looked at was the ratio, and the ratios were no different except for a slightly higher amount of platelet to red cells given in the post-MTP group. But other than that, their FFP to red cell ratio was the same before and after transfusion protocol was initiated. However, what they did find was that the time, they looked at sort of as a group, the timing of this transfusion. And as a group, they found that the post-MTP group, that's when they had the protocol where, you know, in their institution, they gave 2 coolers, each 6 red cells, 6 FFP, and a pack of platelets. And they found that the timing to transfusion was a lot shorter in the post-MTP group, meaning that people got their type-specific products sooner than before in both FFP and platelets. And so as a result of that, when they standardized all the numbers, they found that the mortality of the patients in the post-massive transfusion protocol era had a significantly lower mortality compared to the previous group of patients. And so as a result of that, in their paper, they were able to conclude that, you know, given that it's a retrospective study and all its limitations, that massive transfusion protocol does decrease mortality in the trauma patient that is bleeding. So that's one center. It's difficult to kind of, because when you look at the group of patients who require massive transfusion, it's really ultimately about 2% of your trauma population. So no single center is going to have a large amount of data. And so what one of the groups did was put together a multi-center retrospective review of the outcomes of massive transfusion, because only then can you get a large enough sample population to overcome some of the statistical errors that are inherent in small studies. And so this was a prospectively collected data set of trauma patients. Really the original goal was to evaluate the risk for a multi-organ failure, and it was out of 7 institutions over a period of 3.5 years. And they took those numbers, which contained transfusion ratios, and evaluated whether or not a high ratio compared to a low ratio improved mortality. And what they concluded was that it is associated with a lower mortality. And what you'll see is that in crude numbers, they weren't able to find that. When they just grouped the patients, which they had about 100 patients who were in the high ratio of transfusion, that's close to 1-to-1, and then the low ratio, they found no difference in mortality initially. This was before they played with the data. You can always play with data in a retrospective review by plugging in different regression models to make your numbers look like what you want it to. And so when you put in crude numbers, that's just basically numbers the way it is out of your study. There's no difference in mortality. Bleeding patients are bleeding, and there's no difference when you change the ratio of transfusion. However, what they did find was that there was a significantly higher number of nosocomial infections in the high ratio group, and a significantly higher percentage of ARDS in the group of patients who have a higher ratio of transfusion. Well, when they did regression analysis and broke down the patient population and really kind of analyzed death within the first 24 hours, well, the higher ratio of transfusion gets you past that first 24 hours. The mortality rate is significantly lower in the high transfusion group compared to the low transfusion group of FFP to red cell ratio. So when they broke it down, which is why ultimately they can make that statement that they do as their title, which is transfusion ratios greater than 1 to 1.5 is associated with a lower risk of mortality after massive transfusion. And really they should add in the first 24 hours, because as that pans out, it doesn't really, you trend it out over time, it doesn't really change the mortality. Another study. Out of transfusion, this is a retrospective evaluation of 214 patients who were massively transfused with the 2 different ratios of transfusion. Again, what you look at is the plasma ratio, and they broke it down into the different groups. And initially what they had done was do a high, medium, and low group. And then because there's not enough really data to support individual analysis, what they did was combine the 2 low groups so that you really have 2 different groups of patients to look at, the high group and what is now called the low transfusion ratio group. And what you look at is survival, and basically they were again able to show that the 24-hour survival is significantly higher, but in addition to that, they were able to show that at 30 days, the high ratio of transfusion group was also, the mortality rate is also significantly higher than that of the low group. And finally, this is really a paper out of California, which retrospectively over a 9-year period looked at the platelet transfusion, because remember in the initial paper, the amount of platelets transfused is significantly, when you do a ratio that is significantly higher than what was previously known, then that improved mortality. And so what they did was look at the ratio of not just plasma, but the ratio of platelets transfused to red cells, because platelets is often the last thing we give back in the old way of transfusion, because we would give FFP before we would give platelets first, because you kind of waited until that dropped down to less than 50,000 before you gave platelets, which in hindsight may be a delay in resuscitation. And so what they looked at was the different types of ratios of platelet transfusion and the overall mortality of their patients. And what they had really, over that 9-year period, they had about 32,000 patients, and out of those, 2% were massively transfused, and that data is similar throughout the country in trauma centers. About 2% of your trauma patients will be massively transfused over time. And what they found was that they looked at 12 hours, they not only looked at 24 hours and 30-day mortality, they looked at 12-hour mortality. And in 12 hours, they found a significant difference between the high ratio group and the low ratio group in terms of mortality. That's getting you past that hemorrhage state into that next sort of stage of resuscitation, where you're potentially able to go back to the ICU and come back to the OR. And then again, they looked at mortality in 24 hours. And basically what they're able to show is that everything else equal, platelet transfusion at a higher ratio decreases your mortality rate in the bleeding patient. When we look at our data, because our protocol was basically initiated in July of 2010, we've been putting some numbers together, trying to figure out what our numbers look like compared to the rest of the country. Before MTP and after MTP, our patients were similar in types of injury severity and age. And when we matched them, what we found was that the mortality, although the numbers is slightly lower, is not statistically significant. So post-initiation of our protocol, we had a slight decrease in mortality, but when you do the statistics on that, it's not statistically significant yet. And that's either we don't have enough N, or like everyone says, there's a statistical bias, and in some centers, when you don't play with the data and ultimately do regression and sub-analyze the different hours, you may not find a difference in mortality of these really sick patients who normally would go on to die. But what we did find was that our patients in the post-MTP era ultimately had a lower hospital length of stay. Their ventilator days and their ICU days are really no different compared to the pre-MTP era, and obviously this is a data set that we're continuing to collect and analyze, as is the rest of the world. So all those papers that I've showed you are retrospective data. Most of them showed a trend towards a survival benefit in the higher ratios of FFP to red cell transfusion. And you have to recognize that retrospective studies are flawed by survivor bias. And also, in a retrospective study, you don't have the complete data set. You don't have the randomization that is in a prospective study. But none of these studies, when you look over everybody's reports of improvement in mortality and other outcomes, there's no worsening of outcomes that are suggested. So, for example, no one has come out and said that there is significantly more infectious risk, there is significantly more ARDS in this patient population. There's not. And so because of that, I think this particular set of guidelines can still be used because when you have to deal with dilutional coagulopathy in a delayed fashion, it becomes a problem for not just the patient, but the whole resuscitation process. And so having a standard organized way of doing resuscitation is important, which is why I think the protocol has utilization on multiple levels. And so what we really want to do is prevent coagulopathy and dilution, and it's not the problem of resuscitation. You have to remember that it is a problem of the bleeding patient. They're bleeding. You have to give them the components that they're bleeding, not just the red cells, because they're bleeding plasma as well. And so early control of hemorrhage can save lives. And if you have active bleeding that's really initial or during resuscitation that's greater than 1,500 mLs of red cells, that can ultimately cause dilutional coagulopathy in adults. And in an adult blood volume, that's between 4.5 to 5 liters, and pediatric blood volumes, that needs to be calculated out, weight-based, that is a significant amount of bleeding. It's roughly a quarter of your blood volume. Once you bled that out, you're going to start to see coagulopathy. So really, in doing the guideline, you have to know that you have 2 phases of resuscitation. Your immediate phase of resuscitation, which is hemorrhage control, which includes surgical control and replacing the ongoing losses. And then the maintenance phase of correcting the coagulopathy and the acidosis and the other metabolic derangements that happen. And really the ultimate goal, all of this done sort of in parallel, is to avoid dilutional coagulopathy. So this sort of brings us to the reason why we're having grand rounds today. What is the fastest way to get blood at UHS? Anyone? Right. Crash blood. Remember that. If you're in the OR, on either side of the curtain, and you need blood, you need crash blood right away. That's going to get you the fastest and the most number of units of blood. Not the protocol, crash blood. Ask for crash blood first, and then initiate the protocol. So the protocol will give you 8 units of blood, red cells, 8 units of FFP. They come in 2 different coolers, a red one for the red cell and the blue one for the FFP, and the platelets hanging in that little plastic bag right here. This is where the platelet's going to be. It's going to be next to all your IV tubings, because a lot of the times you won't know where the platelet is because everybody's always looking for the platelets. It's not in the cooler. It's hanging outside of the cooler in a plastic bag. So you initiate the MTP by calling the blood bank. Well, how do you stop it? You send coolers back with blood products in it. That is a signal that the MTP has stopped. That is a problem that we have found because sometimes we accidentally send a cooler back with 1 unit of FFP in there or 1 unit of red cell that we forgot to take out. Well, because of that problem, now there's a second stop. So you send a cooler back with a product, then that's going to prompt the blood bank to call you or the attending surgeon or anesthesiologist and ask you if that MTP has stopped, because we don't want you to accidentally stop an ongoing MTP. So that is sort of the way that the whole process goes. Call the blood bank to initiate it, but that is not the fastest way you can get blood. The fastest way you can get blood is the crash blood. And they come 8, you can get 8 O-negs at a time. And in the ER, we're starting to get FFP with our crash blood for the acute resuscitation of the trauma patient downstairs. Okay. And that's it. Questions?
Lily, you presented our data, and then there was the multi-institution study with Gene Moore. And I'm sure they were matched for age, gender, injury severity score, and probably CNS injury. What about time from injury to arrival? That seems like one of the big factors that's going to determine whether somebody needs transfusion or massive transfusion, in addition to the type of injury.
None of the data really kind of look at the pre-hospital timeline. And that's what you're asking, right?
Right.
Nobody looks at the pre-hospital timeline. It's really sort of from the minute you hit the door, and then people are looking at 12-hour mortality, 24-hour mortality, and then ultimately 30-day mortality.
Because I've heard Gene Moore talk about it, where it was like 15 minutes in Denver. Have you heard them talk from time of injury till arrival in their ER? Or that short a time period?
Not on that specific issue. I mean, that's fairly typical for your urban ground transports, 15, 20 minutes. But for those of us with a broader catchment area, like we have all the way down to Harlingen, the local transport is going to be very different from your...
I thought the only way we could match that would the assailant would have to put his victim in the EMS vehicle and then shoot him in the vehicle. Just getting around San Antonio, but somehow they can do it in Denver.
No, I think our in-town transport time is definitely around 20 to 30 minutes. It's no more than that. But that's not the majority. See, those aren't the patients that are ultimately going to exsanguinate and die. If you look at our patient population, it's not that penetrating trauma from over by Wilford Hall that comes in that has a higher mortality risk. It's that blunt trauma patient with multi-system injury and bleeding from several different cavities that's going to die and has the higher mortality. And those are the patients that I think when you look at, and most of the civilian data is not as impressive as the military data, is because of our blunt trauma ratio to penetrating ratio, because they're looking at the penetrating ratio, which is significant. They're 90% to 10%, whereas ours is like our penetrating ratio is probably 20 to 30% at best.
Big difference. Dr. Dan?
I was going to see if Dr. Eastridge or any of our military colleagues had comments.
Well, I had another question for you, Lillian.
Dr. Bauer, could you push the button? Gotta hold that.
Not the Harlingen.
Oh, okay. I thought I could probably talk loud enough for Harlingen. So, especially for the younger members of the audience, how do you decide when to sort of pull the trigger? What are the predictive factors that will lead you to sort of pull the trigger? What predicts those patients that need massive transfusion?
So I think that's a really good question. And really, a lot of it, you can't just go up to a patient and say, well, that person's going to need a transfusion because based on experience, but there are numbers that you can look at and things that we do, right? So some people have developed an algorithm for checkboxes of X, Y, and Z, and these X, Y, and Z numbers are systolic blood pressure less than 90, heart rate greater than 120. Some people use a heart rate greater than 105. GCS less than 8, a base deficit that is less than -8. Those are triggers that you're going to massively transfuse a patient. One of the other things is a positive FAST. So a hypotensive patient with a positive FAST, that person's going to need massive transfusion. And what we don't want you to do is go down the list and look at all these things and do your check boxes, because there's a thing on MedCalc that you can actually predict. It's called the TESH, and that actually helps you predict whether or not a trauma patient will need massive transfusion. If you go through and do that, it's taken 5 minutes, you've delayed the transfusion process. But if you have a hypotensive patient in the ER who's tachycardic, multi-system injury, and you do a FAST and it's positive, that person's going to need massive transfusion. Go ahead and initiate it. We'd rather you initiate it and us send back the blood than delay the initiation to calculate out any kind of numbers. Another thing to look at is acidosis, so a pH less than, initial presentation pH less than 7.1. Those are indicators, base deficit, pH, and then vital signs that are important. Which is why a lot of us, when the patient rolls in and they're tachycardic but normal tensive, and a young trauma patient who has actually the systemic reserves to maintain their pressure, even though they've lost a significant 20 to 30% of their blood volume, they're still normal tensive, We look at tachycardia as a sign. Some of us also look at the narrowing of the diastolic-systolic pressure as a sign of impending hypotension and the patient crashing. So those are things that you can look at.
Environment, it's also a penetrating mechanism.
Dr. Richards, what about the military? That paper from 2006 had Dr. Jenkins, and I believe he was here and presented about the use of whole blood and the benefits in theater. Are they still using whole blood?
So the difference within the military environment is that one caveat is now that we've looked at all the data from our massive transfusions, and it really hasn't improved our mortality from 60 to 20. Now it's more like it's improved it from the baseline, looking at all comers, was about 38% mortality, to a mortality now that's right around 10 to 15% for patients that are massively transfused. There are some subtle differences between the military and the civilian environment, one being how we achieve that balanced resuscitation. Because of some of our facilities are in forward environments where we don't have a robust supply of component therapy, often we have to rely on the walking blood bank or the use of fresh whole blood. Now, frankly, fresh whole blood, it's what you bleed. So when you resuscitate patients with fresh whole blood, I personally think it's magic. What do you think, Travis?
I would agree. You see a patient coming in, and clearly they're in trouble, oozing diffusely, bleeding profusely. Warm, fresh whole blood is it's like magic. It just really dries the field up. It's really quite remarkable.
In addition to our
Sort of personal experience, having been there, the data would substantiate that the patients that are resuscitated with fresh whole blood, and there are competing camps, but it's at least as good as component therapy for massive transfusion.
Any other questions?
I was going to say we also have Drs. Harrison and Olson here from Blood Bank, and I'd welcome any of their input. I want to thank you for coming.
So it was just to clarify a few things on the crash blood. And so, yeah, if it's in the EC and you call for crash blood, you're going to get, we bring down 4 OPAs and 4 ONAGs. So they're not going to get just ONAG. And the idea is that it's because you don't know the blood type. And they'll get the 4 ONAGs, and then if they need more, they'll be switched to OPAs. And NMTP, that means that they're going to be using a lot of blood by definition. We would automatically switch the people to RH positive, even if they are RH negative. So I want people to realize that once they call an MTP, even if they're RH negative, they'll be switched. Even if it's a woman, they will be switched, because you won't be able to keep an MTP in RH negative. And then the other comment was that's something that's not often so confusing, so I just wanted to clarify that. And it's on the platelets. So you have to really be very careful on these platelet ratio, that, different, and you had one where you talked about a 1-1-1 ratio, 1 red cell, 1 FFP, 1 platelet. So what they're talking about there is what we call whole blood platelets. And they're platelets that are made from a unit of whole blood. You never see that in practice, because those platelets, if they exist, which there are very few places where they actually make platelets from whole blood these days, they're going to get pooled, and that's what people will call 6-packs. They'll pool them in packs of 5 or 6. The majority of the platelets that are in use now are by apheresis, so they get collected from a donor by being put on a machine, and all that get collected is platelets, not red cells, and so on. So you collect the equivalent of 6 units of whole blood platelets. So some of the ratios showed the platelet as being 1 to 8 or something like that. There they were talking about apheresis platelets. We try to make it so that we call them doses, so that people are, whatever it is, they ask for platelet, they get either an apheresis platelet or a pool of platelets. As far as the number of platelets, it's the same, and that way it's easier. We call them doses, but just so I wanted to clarify that, because that's often very confusing on those ratios.
Does anybody look at the blood as far as how old it is? Or, we're always under the impression that it's like HEB. They're going to get the product that's about to expire sitting out in front of the gallon of milk that has 2 days left. Are you pulling the oldest units first?
We're pulling the oldest units first.
Okay, so just so everybody understands that we're...
TPs, you get to the fresh post pretty quickly.
Oh, you do? Okay.
Yeah.
How many units do you normally have in the blood bank? Just out of curiosity.
Depends on the blood types. And for O, I think we have 100 units of O usually, and about the same of A. And then B and AB, we have much less because they're less likely to be B and AB. And then we could always switch them to, if someone is B and we have very little B, then we'll switch them to O. And if someone is AB, there is no AB, so we usually switch them to A.
Yes, Dr. Jatoya.
I was wondering if you could comment on what the holdup is on conducting a randomized trial for something like this. First of all, as you point out, there's a huge survivor bias. And second thing is that since the death rate is so high, you wouldn't need that many patients to conduct a randomized trial. So what's holding it back?
I think because intuitively it makes sense to all of us to use the protocol. From a personal standpoint, I know that ultimately I think it's going to be no different in survival, which is, I guess, my personal bias and belief, because we're dealing with Humpty Dumpty. These patients who require massive transfusion in the civilian world, most of them, if there's not a single isolated bleeding source that you can fix, they're bleeding from multiple orifices, and they have a big systemic burden of injury. And so that ultimately, even though you can get them to survive the first 24 hours, these patients, for the most part, have a high risk of mortality. And so, but if you look back at all of our individual experiences of resuscitating a bleeding trauma patient, as a resident, you knew that, 7 or 8 units of blood into it, you're sitting in the ICU, and all of a sudden you get the labs back, and it's 3 hours later, all the coagulation factors are out of whack. Your platelets are low, you're giving them FFP, you're giving them cryo. So it's the whole idea of, it's going to happen, why not prevent it from happening? And so that's why I think the majority of us have not jumped on a prospective trial. And again, it's one of those things where I think you're going to need a multi-center trial, even though you're not going to need a whole lot, like your N's not going to need to be huge, but you're going to need quite a bit of patients. When you look at overall a 2% rate of patients who need massive transfusion at any one center, it's going to take a few centers to get together and do that study.
Lily, do you ever see any patients with irreversible shock? Now we're talking about people dying from...
I have just one.
Hypothermia. Just one?
Just one in my limited
Myers?
Experience. He's seen two. Yes. No,
I'm just wondering. That was obviously one of the big things, but probably with resuscitation and transportation. So now you're talking about the hypothermia, the coagulopathy problems, and the acidosis, rather than irreversible shock.
I think the patients that are more difficult to correct or reverse are the ones that we get in transport, because if you'll realize, our catchment area is basically the size of West Virginia. And that's a pretty big area to come from, especially if you have a significant burden of injury, to come from like Brownsville or Harlingen. You're going to make that 6-hour trip with a base deficit of -20 showing up at our door. None of us are God or Darwin, so we can't really fix that.
Yeah, we had one recently die of a ruptured spleen after a long transport, who unfortunately had been mistriaged, although I can't really blame the EMS folks. There's 8 people injured. The ones with obvious extremity fractures got sent straight to San Antonio. The old lady who was walking around at the scene pulling people out of the cars got sent to the nearby ER, and then dropped her pressure after arriving to the nearby ER, got transported here. By the time she was here, she was 3.5 hours out, and she coded on the helipad. and ended up dying of a ruptured spleen that could, easily have been saved if she had been transported correctly. But
So there's no general surgeon at a local hospital?
not at this one. And that's the thing. We're working, and Dr. Myers and Stewart and Eastridge and our folks have been working with the regional, South Texas Regional Advisory Committee to help sort out some of these details out in the trauma, in the periphery as part of the bigger trauma system. But we do occasionally see an irreversible shock, but they're usually associated with longer transport.
This is some of the things that Dr. Stewart and I have been looking at as far as everybody knows there's a shortage of general surgeons in this country. There's been a 25% decrease in the number of general surgeons over a 25-year period. And looking at Texas, there's 254 counties, 20 have no doctor, another 100 have no surgeon, no general surgeon. Now, that only accounts for about 5% of the population. When we looked at the population of Texas at 26 million, you should have 7 general surgeons per 100,000. It's dropped in the past 10 years from 6.7 to 6. That translates to 275 general surgeons alone are needed in Texas. Total doctors about 14,000. If you look at it by county, though, it's even worse. And the number is like 450 general surgeons are needed in Texas alone. So there really is a crisis, and it's a shame that somebody like this could not go to the local hospital.
Right, and I think this patient illustrates the point that she didn't need a massive transfusion protocol. She needed surgical hemostasis. And I want everybody in the room to understand there's no substitute for early surgical hemostasis. You can transfuse all you want if you don't stop the hemorrhage, if there's a surgical hemorrhage. Now, these patients that come in with the 2 femurs and the multiple rib fractures and there's no real surgical site, they're a real challenge. But the ones with surgical sites of bleeding, they need surgical control.
All right, thank you. And I think our anesthesia colleagues need to get going. If they don't get that 7:30 start, they won't get their variable incentive pay. All right, thank you very much, Lily.